He will tell us about the surgical aspect of severe pulmonary embolism.
Dear Chairman, ladies and gentlemen, thank you for having invited me to discuss with you the surgical aspects in this entity. According to the Swiss language map, I now should speak in Italian or Romansh. You're lucky, neither of these languages I do speak, so I continue in English. Well, if we are talking about severe pulmonary embolism and the surgical setting, then we need to divide between the acute pulmonary embolism and the chronic pulmonary thromboembolism. I would like to start with the acute setting. The acute pulmonary embolism has a mortality of about 30%. 2/3 of the deaths are within the first minutes, and it is the most common cause of death without any clinical diagnosis. The symptoms are very unspecific: dyspnea, tachycardia, chest pain, hypotension, as well as the laboratory parameters are very unspecific, though there is an elevation of D-dimers in about 90% of the cases. The causes for acute pulmonary embolism, thrombus formation, due to this Virchow triad with vessel wall lesion, stasis, and hypercoagulability. Fat, tissue, bacteria, parasites, foreign bodies, there is a lot of possibilities. We, doing surgery, need a couple of diagnostics prerequisites, which is the chest X-ray, showing, for example, the Westermark sign. We would like to have a pulmonary angiography, multi-slice CT, where you can see this saddle-shaped embolus, MRI, and echo. And in the echo, the most important signs are the D-shaped sign, meaning a shift from the ventricular septum from the right to the left side. There are a couple of treatment options in the acute setting, and they are again divided between a patient who is hemodynamically stable and those who are unstable. If the patient is stable, you can start with anticoagulation, IVC field or whatsoever. And in the unstable patient, there's also a huge variety of methods: thrombolysis, embolectomy, ultrasound, aspiration, rotational embolectomy, thrombus fragmentation, and in the end, it is the surgical embolectomy. But this is in the end. Because nowadays, unfortunately for us, there are only little indications for surgery in the acute setting. And these indications are if the patient has a contraindication for thrombolysis, if the patient had failed thrombolysis or any catheter-assisted embolectomy, and if the patient is thus unstable that he's presenting shock signs, and in this setting he has to be operated. Of course, the operation needs to have a surgical expert team, and the resources in this special hospital have to be available. There's a little addendum for the surgical approach, which is if you, by chance, diagnose an additional intracardiac thromboembolism with huge floating masses, and if you have a patent foramen ovale. Now, historical considerations: the first such operation has been done in 1908 by Friedrich Trendelenburg, who at that time was director of surgery in Leipzig University Hospital. And he described this method, and he did it in 2 patients. All of them died due to severe postoperative bleeding. The first successful operation has been done in 1924 by Kirschner. And then it took a couple of years until the next surgeon became brave enough to do this operation. And in the 1930s, it was John Gibbon who experienced the death of a young lady due to pulmonary embolism. And that caused him to think about the situation and the possibility to have an extracorporeal circulation invented. And it took him another 23 years to have the first operation done, and that was in 1953, where the first heart operation has been done with the extracorporeal circulation. But the first pulmonary PE done with the support of the ECC was done in 1961, and it wasn't Gibbon, but it was Denton Cooley. The procedure itself is quite easy. Via median sternotomy and bicable cannulation, the patient is operated under normothermia. You can do this with the fibrillating heart or the arrested heart. You incise the pulmonary trunk. If you need, you can incise additional aspects of the anatomy. Then you grasp the emboli. At that time, the anesthesiologist tries to ventilate the lung so that debris can be mobilized. You also can open the pleural cavity and manually massage the lungs to mobilize these emboli. Afterwards, you close the incisions, and then you open the right atrium, and via this incision, you can inspect the right atrium and the right ventricle and decide whether there are more emboli to be taken out. Afterwards, control CT, Doppler of the venous system to prevent recurrence of emboli, and then heparin and Coumadin for 6 months. This is a case where surgery, we think, is the better situation. The right atrium is opened, and you see this huge clot in the right atrium. And then we started to resect this clot, and this clot is a huge one in the right cavities, right atrium via the tricuspid valve, right ventricle, and the pulmonary artery. And then after opening the trunk, the pulmonary trunk, there was another huge embolus in the left and right pulmonary artery. So in the end, there were 2 emboli, one in the lung arteries, right and left. And this was the aspect from the right heart with the pulmonary artery, the right ventricle, the area of the tricuspid valve, the right atrium, patent foramen ovale, and the left atrium. Now, the results are, well, they are not that good. It has been looked at by Stein. He reviewed a series of 41 publications. Data came from 1961 to 2005, and the mortality ranged between 6 and 64%, with an average of 30%. One could see that the average mortality rate decreased with having more experience, such to say, after 1984, the mortality rate was average of 20%. The indication for surgery in this review were 74% hemodynamically unstable patients, 32 of those had a cardiac arrest, and 19 had a contraindication for thrombolytic therapy. And the outcome, the mortality, was linked to the percentage of cardiac arrest, meaning the more sick the patient was, the higher the mortality of this surgery was. There's a subset of patients in this study by Menevaux. He looked at 40 patients out of about 400 patients who had re-embolism. And out of these 40 patients, 14 had been operated and 26 had repeated thrombolysis. And the death was 7% in the surgical group and 38% in the repeated thrombolysis group. Bleeding complications were less in the surgical group compared to the thrombolysis group. And in the end, 79% had an uneventful evolution in the surgical part and only 31% in the thrombolysis part. Meaning that surgery today is indicated in hemodynamically unstable patients in the presence of huge emboli in the cardiac cavities, in the presence of anatomically abnormalities such as patent foramen ovale. It is a high mortality operation, but it's a kind of a salvage treatment because we are in the end of the treatment possibilities, and it is advisable in the subset of recurrent emboli. Now, looking at the chronic emboli, this is kind of different compared to the acute setting. The nature of chronic thromboembolism is an obstruction of the pulmonary arteries by a single or recurrent emboli without complete resolution. The 5-year survival in these patients is dependent on the mean pulmonary artery pressure, saying that having a pressure more than 50 millimeters of mercury, you have a mortality, 5-year survival, of about 10%. If the mean PAP is more than 30 millimeters of mercury, you have a survival rate of 30%. If it's lower than 30 millimeters of mercury, then you have a chance of 5-year survival of 90%. Endothelialized residua obliterate or significantly narrow the pulmonary arteries. The incidence of this chronic situation is about 0.6 to 4% in survivors of acute pulmonary embolism. The incidence is 10% in patients with recurrent PE. And there's an incidence of about 0.1, very low, in the treatment of all patients with PE. The first, this kind of operation was done in 1957, and since then more than 3,000 cases are reported in literature. It's a bilateral procedure, and the idea is the total removal of thromboembolic material. The pathophysiology of this disease, it's a chronic disease, and we have chronic lesions in the vessel wall, and they change into fibers and elastic fibers, and finally these become endothelialized. You can see this in this cross-section of a pulmonary artery with these bands and webs that are persistent in the arteries. But there's a second thing, and in the areas of the lung that are now much more perfused, there's kind of a reactive reaction, kind of an Eisenmenger reaction with a vasoconstriction of small vessels, and that leads to an hypertrophy of the media with a finer sclerosis. So it's a mixed form, the chronic setting, with a mechanical obstruction, which is surgically accessible, and with the irreversible vasculopathy, which is not surgically accessible. The indications for this operation, patients have to be in NYHA class 3 or 4. Preoperative pulmonary resistance has to be greater than 309 centimeters. It has to be surgically accessible in the lower or segmental pulmonary arteries, and patients shouldn't have a severe comorbidity. We need a diagnostic setting with a ventilation and perfusion scan, with a CT scan, multi-slice CT pulmonary angiography, and in the end, this kind of patient, he qualified for surgery with an embolectomy of these thrombi. And this patient with a kind of patchy aspect, with a mosaic aspect, and a very distal subsegmental arteriopathy, was no surgery indicated, so he wasn't operated. Surgery is done with median sternotomy under total circulatory arrest with a hyperthermia of about 20 degrees. This is why, because there are many vessels created between the systemic and the pulmonary arteries, and they would cause bleeding, so you couldn't see anything if you wouldn't stop the heart-lung machine, and the arrest is about 20 minutes per side. You start on the left side with an incision in the pulmonary trunk, and then you go to the right side. Maybe you have to incise the lower segment of the artery. You have to dissect the caval vein, but this is no problem. And then the most important thing is you have to find the layer in the media to dissect all of the material, and it's not just an embolectomy, but it's just you have to do a thromboendarterectomy, and this is how it looks like afterwards. Afterwards, you can rewarm the patient, and if you need to do any further operation, you can do it in this setting. In the postoperative management, you have to look at persistent pulmonary artery with 25 millimeters of mercury, which is present in about 10% of the patient. You have to look for the reperfusion edema with an incidence of 10 to 15%. You have to look at rupture of the arteriotomy because it can bleed. Patients often have nosocomial pneumonia, hemoptysis, intrapulmonary bleeding, and the rethrombosis rate is rare. The outcome is dependent on the preoperative vascular resistance, meaning patients who have a vascular resistance lower than 900 dyne is about 4%, but with patients having a resistance more than 1200 dyne, it's about 20%. But the hemodynamics are very much increasing afterwards. This is preoperative setting for a mean pressure with 48, postoperatively 27 millimeters of mercury, and in follow-up of 24 months, it decreased to 24 millimeters of mercury. Same with the index, 3.7 preoperatively, 6 postoperatively, and in the end, 4.8. And also the long-term outcome, according to the NYHA classification, preoperatively, none of the patient was in NYHA class 1, but 3 months later, 30% of the patients were in NYHA class 1, NYHA class 4 practically vanished, which is the same after 12 months, 40% in NYHA 1 and 50% in NYHA 2. Concerning the 6-minute walk test, also an increase of the patients after 3 and 12 months. And in this study from Canon, you can see the survival rate. It's about 70% after 10 years, but again, it is dependent on the knowledge of the surgeon and the technique you are using, indicating that the last patients that had been operated since the last 5 years had a very high, in this case, a very high survival rate compared to those who had been operated in earlier years. Now, this is surgery, the acute surgery, and there are a couple of other possibilities, medical treatment and very recently the balloon angioplasty. And in this overview, it is said that the balloon angioplasty is a good idea and a good method, it's a good means to treat these patients. But which patients should be treated with this? The first publication was in 2001 by Feinstein, but he was very unsuccessful because of postoperative pulmonary edema. So he stopped this operation. And in 2012, the Japanese groups, they have re-established the method, and since then, 127 patients have been documented. It is a multiple procedure with smaller balloons nowadays, with an average 5 sessions per patient. One has to take care for vessel rupture, one has to take care for reperfusion, lung injury, but it's gaining increasing interest, and it's amenable for those patients who have very peripheral PE in the subsegmental area. These are a couple of signs, pictures showing the results. This is pre-angioplasty and this is post-angioplasty. You can see here the rarefication of the vessels, and now they are pretty nice present again. Same in this. Here in the pulmonary angiography, you can see this web in the vessel. In the magnification, you can see it much better. In the IVUS, there's practically no flow, and after the angioplasty, you can see a much better result with a good flow in the IVUS. Same thing here, closed after angioplasty, and you can see a very good result. The correlation of the result is, meaning the decrease of the pulmonary arterial pressure, is dependent on how many sequences you have, how many interventions you have, saying the more you have, the better the result is. So in conclusion, I would state that surgery for the acute pulmonary embolism is the last treatment option. Indications are contraindication for thrombolysis or failed thrombolysis and hemodynamic instability with shock. In the chronic setting, the PEA so far is the standard and the recommended treatment. ECMO should be a standard of care in these patients, so you need to have this possibility to overcome postoperative pulmonary edema. So far, the role of percutaneous angioplasty needs further evaluation, but it's increasing in interest. And the team deciding whether the patient is curable, well, they have to decide, and before other treatments such as medical treatment or the angioplasty can be used. Thank you very much for your attention.